I'm delighted to speak about Trillium. Many of you may have already seen some of the slides that I will be presenting today. Maybe there is also some new material for you to check out. So first of all, let me give you a little bit of a story for those of you, the few of you that haven't heard about it. I had the extreme privilege and pleasure to work with some of you, especially Deepak Kardre, in the first iteration of Trillium, which essentially led the way for Trillium II. So we worked under the EU-US MOU for cooperation on interoperability, and we tried to then connect two very important projects, EPSOPs in Europe, a large-scale pilot, with a meaningful use project that had received a lot of stimulus money in the US. So we did a lot of work. Actually, Deepak was responsible for the feasibility study, which reflected on standards, cross-vendor integration, incentives, clinical research, security and privacy, innovative business models, and education. The outcome of that project was a recommendation that was implemented and supported by Trillium II that I will be discussing, and the lessons I will be sharing regarding connection with electronic health records, and especially cooperation between Trillium and C3-Cloud through the excellent work of SRDC. So the recommendation was to advance IPS, International Patient Summary Standards, that would enable people to access and share their health information for emergency or unplanned care anywhere and as needed. This, by the way, very close to the mission of HL7 as a standards developing organization. And at a minimum, the recommendation went on, it would include immunization, allergies, medications, clinical problems, past operations, and implants. So the question is, how do you do that? And how do you actually connect these information items to the electronic health record in a way that can assure quality, interoperability, and usability of the information? The partnership here, to give to you, is 14 countries, 7 health systems, a quite balanced consortium from Europe and the US. So to address the challenge of promoting international patient summary standards, we decided to work along different action lines, and this was quite challenging. We looked at the social value of patient summaries. We worked with WHO, with the World Economic Forum. We promoted the governance of IPS specifications, because people think about this project, they rarely think about continuity, what will happen to the next one. And then education and learning, and then policy, how do you form policymakers? And then how do you collaborate with standardization bodies, which frequently revisit the same problems again and again, probably in different ways? And how do you actually reach out to the people that are doing the implementation? And how do you look to the business that will create the new services? And how do we learn from each other, the global community of practice? These were questions that were addressed by Trillium II and are really still very pertinent. We also needed a kind of a vision statement. And the vision statement for patient summary appears here, which is larger than the international patient summary per se. The IPS is considered as a window, an active window to a person's health data, a landing page from which you will access health information across locations and jurisdictions. And you can immediately understand that the electronic health record is just one source, probably split along different locations. And the real question is, okay, so you have this health data, you have this window, you look into the window, what do you do? How it informs your actions? How does it inform your activities? How does it inform your lifestyle? And this is exactly where care plans and the work of C3-Cloud goes. For Trillium, it was about developing standardization resources and new use cases. Another important point for Trillium is that it addressed not only the individual, but also the community, the neighborhood, or in the case of a disaster, which was the case study that we examined with C3-Cloud, the people that were affected by an emergency event. You can think of COVID as another one. We looked at the IPS through a personal lens, and we looked at quality assurance, at health goals, at early warnings. We looked also at specific problems like hypertension or like rare disease management or like vaccination cards for mothers and children or for the elderly or a survivorship passport for cancer patients. And this led to the thinking of a library, of interoperability assets, of reusable resources that can be used and refined every time they are used. Here is an initial one, and here is the contribution of Trillium. Now, all right, we talked about grassroots, we talked about projects. What we learned in Trillium is that you are as strong as the collaborations that you make. A project in itself is like an island, and it doesn't have any impact unless it can reach out to stronger projects. And one such stronger project that I will talk a little bit about, and Gox, I assume later will give you also the details, is the work that we did with SRDC in the context of the C3-Cloud project. We did also other things, but this is not the focus of this talk. So the first collaboration that we did after we signed the collaboration agreement amongst the two projects is that we assembled a group of people that visited in person or remotely the Fire Connectathon in Baltimore. And here is the scenario that was actually demonstrated with C3-Cloud. We actually worked with different fire servers here, but the idea is that you could be able to store the IPS in a fire server, retrieve it, and use it. And the actual use that happened by C3-Cloud was to create a care plan and actually store this care plan in the IPS and then share it again back with the patient. So the patient would have their IPS and they would have a care plan there that is used and created through the guidelines that are in the C3-Cloud platform. So you see the importing of the IPS, finding the patients. Here are the data that were retrieved from the IPS. And here is how the select additional data, and then you can create the care plan. You saw some of that already. Yeah. So after the goals are set, the activities are set, you then export the IPS back. After we did that, we tested that in the Fire Connectathon, then we actually went as live as possible. We participated in, together with SRDC, in the EU Modex exercise in Romania. That was 28 countries all over the world, and not only Europe, and around 2,800 participants. Our section that we worked was the Israeli Mobile Hospital, 150 people, 7 ICU beds, 30 beds in wards. And the care plan was related not to the immediate disaster, but rather in the 2 weeks after the disaster. And this is where people wanted psychological support, where the social workers are very heavily involved with people. And that's where care plans matter. And this is where it was discussed, and we got very good comments from the actual social workers and primary care health professionals. Here is the plaque that commemorates the activity with all the flags around. And here is a set of very tired but happy individuals. So let me go back to the last part of my presentation. And here are some of the lessons learned. We learned a lot. Trillium was a huge educational activity for us all. For me, I think these 7 lessons, in no particular order, is probably the blossom of all we learned. The first one is that you need to know where the information comes from. You need to attest to the level of quality, and you need to know how much you trust the source. And these are not binary. These are not yes and no. There are different levels. And in our work, and as information scientists or in computer scientists, is to actually make sure that we know and we can attest to these elements. The second one is that APIs matter. They are at the crux of business development today, and they will be extremely important. And the art of designing and implementing them is central. The third one is information does not matter unless you use it. So care plans matter for the IPS, and the IPS matters for care plans. We need, however, to focus on daily use, make it easy, and revisit accessibility, especially in the context of trust and security and privacy. For instance, one of the things that we learned in emergencies is that reading and writing on computer does not make sense. They need voice interfaces. And voice interfaces are a whole new game about security, privacy, and access. So we have to think out of the box. Now, for standards organizations and their constituency, we need tools. We need better tools for integration. We need better tools for semantic interoperability. We need better tools for implementation of standards. We also need to rethink about data sets. And some of the work that we currently use on fair data and HL7 FHIR and verification of data is central to that. IPS can be a source for that. Lesson 6 is be aware of the gaps. SDO cooperation is a must, and we should work together and capitalize on the different strengths. And last but not least, probably the most important lesson I learned, education, 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 capacity building, new ways of work is the lesson that changes between success and failure. Here is a summary: provenance, quality assurance, policy, process, actions, transactions, etc. APIs matter, as I said. Here is the case study of Apple, which works with Health Kit, Research Kit, Care Kit, health records all together. So health records are not an island. They need to support research. They need to support the individual patient. They need to support the caregiver. They need to support health professionals. Accessibility matters. I cannot repeat it enough. We should work with voice, not type. Collaboration between standardization bodies. Make sure that we get the feedback and we implement it. We have governance. Just to look at this, IPS has been very successful, but every standardization organization is doing some work. We need to leverage, we need to govern this work. What lies ahead? That's quite exciting. We are working with the electronic health record exchange format and the innovation part in a new support action at HL7. I'm delighted about this because now we will look at the different pieces of the IPS and rethink those lessons in specific cases and case studies, very much like the one from C3-Cloud. C3-Cloud for me has been a very innovative idea. I'm really delighted that SRDC actually created a demonstration that is there for people to see and be inspired by that. Unicom, how do we leverage medication identification in the patient summary? This is a big, big problem, but I do hope that ISO IDMP will be used on identifying medicinal products for the patient summaries. The Vulcan initiative and essentially returning data back to patients. That's also very important for clinical trials, as clinical trials are going out to the community. And last but not least, my favorite, Gravitate Health, on actually using the IPS to look at the data, at information, like the leaflets of medications. Here is the picture that I like, and it summarizes both accessibility, voice, vision, etc., and focused information. So with that, I would like to conclude my presentation today and share with you that everything is about cooperation and education, and it's lifelong learning. Information, the data society that we live, the data economy is changing the game, and we need to be able to adapt working together, we can make it happen. Thank you very much for your attention.
Thank you very much, Catherine, for your presentation.